Hello, this is Dr. Bridwell, and welcome to Cerianna, or fluoroestradiol imaging for PET-CT. We'll introduce the technology tonight and step through it in a three-phase project. We'll start with breast cancer and the background of treatment decisions with respect to estrogen receptor positive breast cancer. We will explain the technology, and then we'll look at some outcomes analytics. I am Dr. Bridwell. I serve as the medical director for SOFI as well as a consultant to GE Healthcare, where I launch new radiopharmaceuticals with respect to the PET-CT industry, as well as serve in cancer navigational services with respect to Appian 360. We do have a chat available tonight, so if you have clinical questions as we progress through this discussion, please use the chat and then we'll answer your clinical questions at the end of the presentation. So disclaimers before we get started. This discussion is the intellectual property rights of Xinexa, GE Healthcare Corporation. This is not medical advice. Clearly, you're all physicians, and we're going to explain the technology tonight, but any clinical decisions you make in your own patients are up to you, and you need to be professional about how you're utilizing this technology or information that we give you tonight. There's no legal liability assumed from this presentation. All the images are from the phase 3 study from Paris and are used with permission from that center. And then if you have any clinical questions, you can contact Xinexa, again, a GE Healthcare company at Cerianna.com. So important safety information just from the package insert. Cerianna is a radioactive diagnostic agent indicated for the use with positron emission tomography imaging for the detection of estrogen receptor positive lesions as an adjunct to biopsy in patients with recurrent and/or de novo metastatic breast cancer. The limitations of use: tissue biopsies should be used to confirm recurrence of breast cancer and to verify ER status of pathology. Cerianna is not useful for imaging other types of receptors, to include HER2 and progesterone receptors. There are no contraindications. Adverse reactions in clinical trials, the safety of Cerianna in patients with breast cancer. The following adverse reactions occurred at less than 1% rate, to include injection pain and dysgeusia. To report suspected adverse reactions, contact Xinexa US Corporation, a GE Healthcare company, at 1-844-946-6392, or the FDA at 1-800-FDA 1088, or www.fda.gov/medwatch. And then for prescribing information, you can visit the website cerianna.com/PI. So to talk about the technology, we're just going to start with a background in breast cancer. And again, I'm sure everybody on this webinar is very familiar with breast cancer. Breast cancer can be a heterogeneous group of tumors. Typically, the biopsy really determines the therapeutic foundation for our breast cancer patients. That biopsy is typically done at one site or maybe two sites. And we do an immunohistochemical assay to look at the estrogen receptors on the tissue. About 75% of all primary breast cancers are estrogen receptor positive. The ER status of the tumor really dictates, again, how we treat our patients, and endocrine therapy is recommended as standard of care for most patients with hormone receptor positive metastatic breast cancer. However, endocrine therapy can only be effective in patients with estrogen receptor positive expression in their metastatic tumors. And there may be some limitations if you're only biopsying a single site to do a more comprehensive assessment. And non-invasive tool like FES may allow you to give it a more comprehensive feel of the biology across multiple metastatic lesions rather than basing clinical management decisions on a single biopsy. So despite favorable outcomes with ER-positive metastatic breast cancers due to some changes in therapeutics that are recently available, the majority of breast cancer deaths occur in that cohort of patients. A notable proportion of patients with estrogen receptor positive primary breast cancers eventually present with estrogen receptor negative metastatic lesions. This is referred to as temporal heterogeneity, and again, we'll discuss that as we move through the presentation. Those patients with a significant component of their disease that's ER negative may not benefit well for endocrine-directed therapies. And the whole idea of this technology is, again, to give us a more comprehensive assessment of the biology across multiple metastatic lesions rather than basing clinical decision-making on a single or limited number of biopsies. Certainly, metastatic disease may not always be amenable to immunohistochemical assays. Clearly, sites that are difficult to biopsy in the neuroaxis or bone lesions can face additional challenges with respect to decalcification artifacts. I'll show you intratumor heterogeneity tonight. So where you biopsy can make a difference. If you biopsy a lesion that has intratumor heterogeneity and you biopsy one side versus another side, you actually may get a totally and complete different answer with respect to fine needle and or core biopsies. Tumor heterogeneity, again, we'll discuss at length. It basically comes in three forms: intratumor heterogeneity, where you can see variability of the biology at a single lesional level; intertumor heterogeneity, where there can be discordance of the estrogen receptors across two different lesions at one phase of management in a patient; and then clearly temporal heterogeneity can occur, where we can see the estrogen status change across time, specifically if we put selective pressure on it with endocrine therapy. The top right-hand side, I want to point you to that 30% number. Estrogen receptor expression is discordant between primary and metastatic lesions in around 30% of the population. And so that 30% number will come up again as we look at some prognostic power of deploying FES with respect to patients and looking at estrogen receptor heterogeneity to guide therapeutic decision-making. So summarizing the unmet need, while 75% of tumors are estrogen receptor at diagnosis, not all patients respond to endocrine therapy. If you look at CDK4/6, about 20% of the patients have primary resistance, and clearly not all initial responders stay responders, and they may become later refractory to endocrine therapy. Unpredictable response and acquired resistance to endocrine therapy may be attributable to tumor heterogeneity as far as the estrogen receptor goes. And so this technology may give us a capability of looking across multiple lesions to discover estrogen receptor heterogeneity in the context of our patients. Because the estrogen status may be discordant within the same patient, a single biopsy may not be representative of the true biology of the tumor burden at whole, and we'll illustrate that with some of the case studies tonight. And in addition, estrogen receptor expression may also change across time, again, temporal heterogeneity. Thus, clarifying the extent of within patient estrogen receptor discordance is critically important for treatment decision-making. To cover the diagnostic agent itself, this is fluorinated estradiol. It targets the estrogen alpha, which is very specific for breast cancer. The patient experience for this, typically we recommend going from the top of the head to the knees. ER-positive breast cancer is typically a bone-dominant disease process, and so we like to incorporate all the distant long bones in the field of view from a PET-CT perspective. We're injecting 3 to 6 millicuries of this. So if you have an older piece of equipment, or if you send your patients to an older piece of equipment, the experience of the PET-CT may take longer because it's 3 to 6 millicuries. And with older equipment, we're typically injecting 15 millicuries of FDG. With newer equipment, the patient experience, the time they stand on the table is actually, or sit on the tables, relatively similar. Again, it depends on the age of the equipment and the crystal technology. The uptake time typically matches what we do with FDG, and it is really wide open with respect to the package insert. 80 minutes is recommended, but it has a very wide area where you can image your patients from 20 to 80 minutes from an uptake time perspective. So inject, wait a period of time, take a picture, similar to what we do with FDG. As you can see on the normal scan on the right-hand side, the liver is the target organ with respect if you open the window up, you'd also see intrahepatic biliary tree and gallbladder commonly and normally. that excretion is into the gut, and that metabolite gets excreted by the kidneys into the bladder. So all of this activity from the liver down is normal. You can see this agent does not normally go to the brain. So we have try to extend the field of view from the top of the head to the knees. You'll notice in the right arm here, there's some stickiness to the radiopharmaceutical. There are injection techniques that are out there to minimize that from a technologist perspective. So the overview of clinical outcomes and overall diagnostic accuracy with this technology, again, it's demonstrated safety, as you saw in the package insert. It does have relatively good sensitivity and specificity that we'll talk about specifically. So with some studies here, both single institutional studies as well as meta-analyses, the specificities, which I'll start with, is relatively high. Estrogen alpha is very specific for ER-positive breast cancer. The other things that potentially give us false positives are normal ovarian, normal endometrial uptake, ovarian cancers, endometrial malignancies, some hormonal sensitive meningiomas, and then we get a diffuse pattern in the lung in some patients that have been treated with adjuvant radiotherapy. It's actually a relatively easy pattern to read through. And so it's a pretty clean radiopharmaceutical from a false positivity perspective. If you have patients with ER-positive breast cancer and ovarian or endometrial malignancies, you need to let your radiologist know because those tumors can overexpress estrogen alpha. Also, if we get intense uptake that's out of proportion to the normal organs, sometimes we'll have to recommend a workup. Sensitivity is a little bit harder of a concept for those of you that are unfamiliar with PET-CT. So let me try to go through it. Sensitivity is directly correlated to a few things with respect to FES. One is the density of the estrogen receptors on the anatomical lesion. Two is the size of the lesion. Three is where the lesion lives in the body. And four, the medications that can impact the estrogen receptors may reduce the sensitivity of the technology. So we'll go through each one of those. So basically, if you're, say, a 3 millimeter lymph node or 1 centimeter lymph node, and you let's take 5 millimeter lymph node. You're a 5 millimeter lymph node and you have a staining of only 10% of estrogen receptors. That 5 millimeter lymph node in the bone or 5 millimeter lymph node in the chest may fall below the resolution of the imaging system, and that's called the partial volume effect. If you take something that's stains 100% and it's a 1 centimeter lesion and you stick it in the liver, we may not be able to see it from a contrast resolution perspective. And then if you're on tamoxifen or fulvestrant, you may suppress the estrogen receptor, and we're not seeing it because you're on medications that interfere with the estrogen receptor. So that really explains sensitivity. And again, specificity it's a relatively easy, few false positives with this technology. So medications that impact the estrogen receptor, you need to avoid them if you can. Tamoxifen is not a big problem, 8 weeks off the medication to preserve the sensitivity of the imaging agent. Fulvestrant is a long time. So as you see, 28 weeks off of fulvestrant before you can preserve the sensitivity of FES. What we typically tell clinicians, if they're going to use this technology and they're considering putting somebody on fulvestrant, you need to do this examination prior to starting that medication because 28 weeks is a long time in a metastatic setting. The good news is CDK4/6 and aromatase inhibitors do not impact the estrogen receptor and therefore do not impact the sensitivity of FES. So let's just look at a couple articles and then we'll look at a couple of case studies. Again, looking at receptor heterogeneity with respect to FES. This is Dr. Yang's article looking at 32 patients with 64% of the lesions were osseous lesions, which is typically what we're seeing with this disease. There was a 33-fold difference in estradiol uptake if you looked at patients between different patients, and an 8 0.2-fold difference if you looked at the same patient among different lesions. Here's that 30% number that I showed you previously. In 28% of the patients, some of the FDG-avid lesions were positive for estradiol uptake and others were not. So about a 30%, which aligns perfectly with the pathological studies, about a 30% of the population has some component of estrogen receptor heterogeneity within the context of their disease. Certainly those patients that are treated and failed endocrine therapy, you select out those clones that are more resistant, and you may actually get more heterogeneity in populations that have seen and failed endocrine therapy. So let's look at a couple case studies. Again, this is a virtual environment. It's more fun live, but we're going to force you to make a clinical decision making and then look at how potentially FES could have changed what you were doing as a clinician. So this is a 59-year-old woman who was treated with stage 3 breast cancer. She went through her therapy. She represented with stage 4 disease. Prior to instituting therapy, the clinical oncologist in this case ordered an FDG PET to restage her. And this is her FDG study on the left-hand side. Clearly, you see bone dominant disease, which again is characteristic for this disease process, multiple hypermetabolic lesions throughout the axial skeleton. You also see a soft tissue surrogate in that axillary lymph node, in the right axillary lymph node. So I just want you to take a look at this MIP, take a look at that clinical history. Again, a 59-year-old woman, previously treated with stage 3, represented with stage 4. Prior to therapy, she got this FDG study. So what do? Treat her systemic disease based on her historic pathology or estrogen receptor positive breast cancer with endocrine therapy, switch the line of therapy to chemo, biopsy the axillary lymph node. Clearly, it's the most accessible tissue. It doesn't have the problem with decalcification artifacts, or order a Cerianna PET CT to get a comprehensive assessment of the estrogen receptors across multiple metastatic lesions, rather than basing your clinical decision-making on a limited view from a biopsy perspective. So I'm going to make you make your intellectual choice here. Again, treat her with endocrine therapy, switch her to chemo, biopsy the axillary node in this phase of management to see what the biology is, or order an FES study. All right, so here's her FDG and here's her FES. And what we see in this case is that for those of you who would have treated her with endocrine therapy without a biopsy, you clearly would have treated the axillary lymph node that was estrogen receptor positive, that was hypermetabolic, but you would not have treated any of her osseous disease. For those of you who would biopsy the axillary lymph node and base your clinical decision-making on the pathology, you would have treated her with endocrine therapy to treat the axillary lymph node that was estrogen receptor positive, but then not necessarily targeted the ER negative disease that existed in her body. For those of you who would have switched to chemo, probably the most correct, although I don't know if anybody answered it that way. But again, the role of FES is really to give you a comprehensive assessment of the biology across multiple metastatic lesions, rather than basing clinical decision-making on a single biopsy site. Clearly, this patient is in this slide deck for a reason. She shows an exquisitely high degree of estrogen receptor discordance across her disease, with only a single lesion actually being ER positive, and that being the axillary lymph node. Another case study, this is a 67-year-old patient with a very similar history. She was treated with earlier stage breast cancer, ER positive, HER2 negative. She represented with stage 4 disease, and prior to starting systemic therapy, they ordered an FDG study to restage her. Here's her FDG study. Again, a bone dominant disease process, which is typically what we're seeing with this disease with respect to FES. And again, multifocal hypermetabolic lesions throughout the axial skeleton. Here is her FES study on the right-hand side. And in the case of this patient, you actually see a lot of her lesions overexpress estrogen receptors. So if you're a radiologist, this is a lesional-based analysis. We do not read these off the MIP image because actually we're doing lesional analysis. We want to see at a lesional level how much of her disease is ER negative versus ER positive. So you need to really step through the lesions and to be able to interpret it. And so here's a lesion that is hypermetabolic that overexpresses estrogen receptors. Here's a lesion that is FDG positive, FES negative. Here is a lesion that has low metabolic rate that has higher FES over accumulation, suggesting a more well-differentiated clone. And in this one axial field of view, she has 5 lesions, only one of which is FDG positive. So when you order this test within the context of looking for estrogen receptor heterogeneity, the clinical radiologist should be saying, number one, yes, it exists or it doesn't exist. And then to what degree does it exist? Clearly, the last patient had a higher degree of ER heterogeneity with really only one single lesion that was ER positive. This patient has significantly more lesions that are ER positive, but she has a significant component of her disease that's ER negative. And I'll show that when we talk about the last case of the night. In this case, we also see some medical oncologists when a patient has significant component of their disease being ER negative, they will actually go after the ER negative disease from a biopsy perspective, because that tends to be the most dedifferentiated clone. And so if it's the most dedifferentiated clone and they're entertaining other types of therapies, PD-L1, PARP inhibitors, they will go after those from a biopsy perspective. So there is some value in directing biopsy by characterizing the most aggressive clones in a patient's body with a non-invasive imaging device. So 2 articles I want to talk about. So the Boers article took a cohort of patients that were going to be treated with CDK4/6. And what they did is they did a baseline FES and a baseline FDG. They treated everybody the same way. They repeated the FDG scan at 8 weeks. And they asked the question, was the response on FDG at 8 weeks predicted by the pattern of FES at time 0? 2 patients from that article, A, B, and C is 1 patient, D, E, and F is a 2nd patient. A is the FDG, B is the FES. Here you see 100% concordance between A and B. All the hypermetabolic lesions overexpress FES, and you can see that this patient had a complete metabolic response in the face of CDK4/6 plus endocrine therapy. D, E, and F is the 2nd patient, D is the FDG, E is the FES. Here you see discordance with only a small component of her disease being ER positive. And you can see that she failed miserably in the face of endocrine therapy because the vast majority of her disease had already lost its estrogen receptors. And so if you're targeting with endocrine therapy and you target patients that have lost their estrogen receptors, they're probably not going to respond very well to that targeted therapy. This was an invasive lobular patient who was on an aromatase inhibitor, and she had a clinical failure going on. So she was represented with back pain. She had an MRI of her back, and she had a really aggressive T11 lesion with bony destruction. And the medical oncologist asked the question of FES. They asked the question, was T11 the only lesion in the body that was dedifferentiated and had lost control from the aromatase inhibitor perspective? Or were there other lesions that were dedifferentiated and ER negative? I.e., do you radiate T11, control the symptoms, control the bad acting clone, and then maintain the line of therapy? Or do you radiate T11 and switch the line of therapy? So that was the clinical question going into the FES study. In this case, the baseline technology was really just MRI. And this is, again, a characteristic FES study with, you can see a diffuse marrow involvement as well as multifocal osseous disease in a more focal pattern. You can see, again, the normal biodistribution in the liver and the intrahepatic biliary tree and the gallbladder in this case. I want to point out that if you look at the sagittal view here, you can see that she's got diffuse marrow involvement of her tumor. But as you walk through T11 here, you see an absence of estrogen receptor expression as measured by FES. It was the only lesion in the body that had lost its estrogen receptors. So this was, instead of oligoprogressive disease, this was monoprogressive disease. And in this case, they elected to radiate T11 and maintain the line of therapy because of her diffuse ER positive disease that was illustrated by FES. I also want to point out that if you're a radiation oncologist, I've shown this a lot to proton therapy units and other units around the US. radiation oncologists get pretty excited to look at delineation of bad acting clones versus favorable clones within the context of the same vertebral body. So this is intra-tumor heterogeneity, where you see the right side of this marrow packed full of good tumors overexpressing estrogen, well differentiated, but you can delineate the line where the unfavorable loss of estrogen receptors are on that coronal data set. So pretty exciting stuff where we're being able now to tease out intratumor heterogeneity, guiding biopsies, again, if you're going after the most aggressive clones to look at other targeted therapeutics. Even in a lesional-based analysis, there can be variability of the biology. So the summary, just to sum it up before we take questions, this is a radiopharmaceutical PET-CT-based agent that can characterize very sensitively and specifically the estrogen alpha status, can allow comprehensive biological assessment around multiple metastatic lesions rather than basing clinical decision-making on a single biopsy site. We did focus groups prior to launch and have seen where clinicians are utilizing this tool, and it really falls into three different buckets. One is to look at receptor heterogeneity in populations of patients to characterize biology across multiple lesions. One is utilizing it as an injectable biomarker in well-differentiated ER-positive breast cancer patients where CT and bone scintigraphy can be problematic and FDG doesn't necessarily work all that well. And that, as an example, that would be your invasive lobular carcinomas. So substituting, if you use FDG in triple negatives, this is a similar, very sensitive injectable biomarker for those well-differentiated ER-positive breast cancers. And then also as a problem-solving tool, if you have a patient with history of ER-positive cancer and some clinical problem, new pleural fusion, and you're trying to figure out if it's coming from breast cancer or some other malignancy, maybe it's a lesion you can't get to easily from a biopsy perspective, this can actually be utilized to characterize estrogen status on anatomical targets to assist you from a problem-solving perspective. So standard of care on the left, biopsy a site, assume the biology is the same, treat the patient. FES, PET-CT, again, non-invasive technology to characterize estrogen receptors across multiple metastatic lesions. What that tells us, though, is we need to know the extent of disease, so we need a baseline technology when we do this tool. The radiologist has to have their hands on that baseline technology. From a package insert perspective, that can either be a CT bone scan and or an FDG PET scan. You saw from Boers and Bottini, there's some prognostic value in using FDG as opposed to CT bone scintigraphy, but it really depends on where you practice in the US and whether you're using FDG in your breast cancer patients. Field of view, top of the head to the knees, and then we do a lesional based analysis. So we look at each of the METs on the baseline tool and then look at the FES to see if it's overexpressing estrogen receptors or not. So the key takeaways, again, this is a non-invasive tool. It's an adjunct to biopsy. It's not typically going to replace biopsy, but it, again, allows you to do a more comprehensive assessment if you're not biopsying every lesion of a patient's body to look at receptor heterogeneity to guide therapeutic decision-making. You saw the Boers and the Bottini article. The Bottini article was an upfront utilization of the technology in patients with stage 4 prior to systemic therapy. And in the Boers article, about 70% of the patients had seen and failed first-line therapy, and about 30% were virgin breast cancer patients that had not seen systemic therapy prior to CDK4/6 inhibitors.
Important safety information, indications and usage. Cerianna is indicated for use with positron emission tomography, PET imaging, for the detection of estrogen receptor ER-positive lesions as an adjunct to biopsy in patients with recurrent or metastatic breast cancer. Limitations of use. Tissue biopsy should be used to confirm recurrence of breast cancer and to verify ER status by pathology. Cerianna is not useful for imaging other receptors, such as human epidermal growth factor receptor 2, HER2, and the progesterone receptor, PR. Contraindications, none. Warnings and precautions. Risk of misdiagnosis. Inadequate tumor characterization and other ER-positive pathology. Breast cancer may be heterogeneous within patients and across time. Cerianna images ER and is not useful in imaging other receptors such as HER2 and PR. The uptake of fluoroestradiol F18 is not specific for breast cancer and may occur in a variety of ER-positive tumors that arise outside the breast, including the uterus and ovaries. Do not use Cerianna in lieu of biopsy when biopsy is indicated in patients with recurrent or metastatic breast cancer. False negative Cerianna scan. A negative Cerianna scan does not rule out ER-positive breast cancer. Pathology or clinical characteristics that suggest a patient may benefit from systematic hormone therapy should take precedence over a discordant negative Cerianna scan. Radiation risks. Diagnostic radiopharmaceuticals, including Cerianna, expose patients to radiation. Radiation exposure is associated with dose-dependent increased risk of cancer. Ensure safe drug handling and patient preparation procedures, including adequate hydration and voiding to protect patients and healthcare providers from unintentional radiation exposure. Pregnancy status. Assessment of pregnancy status is recommended in females of reproductive potential before administering Cerianna. Adverse reactions. In clinical trials of an N of 1,207, the most common adverse reactions seen occurred at a rate of less than 1% were injection site pain and diagnosia. Use in specific populations. Pregnancy. Risk summary. All radiopharmaceuticals, including Cerianna, have the potential to cause fetal harm depending on the fetal stage of development and the magnitude of radiation dose. Advise a pregnant woman of the potential risk of fetal exposure to radiation from administration of Cerianna. There is no available data on Cerianna use in pregnant women. No animal reproduction studies using fluoroestradiol F18 have been conducted to evaluate its effect on female reproduction and embryo fetal development. The estimated background risk of major birth defects and miscarriage for the indicated populations is unknown. All pregnancies have a background risk of birth defects, loss, or other adverse outcomes. In the US general population, the estimated background risk of major birth defects and miscarriage in clinically recognized pregnancies is 2 to 4% and 15 to 20%, respectively. Lactation risk summary. There's no data on the presence of fluoroestradiol F18 in human milk or its effects on the breastfed infant or milk production. Lactation studies have not been conducted in animals. Advise lactating women to avoid breastfeeding for 4 hours after Cerianna administration in order to minimize radiation exposure to breastfed infant. Pediatric use. The safety and effectiveness of Cerianna in pediatric patients has not been established. Geriatric use. Clinical studies of fluoroestradiol F18 injection did not reveal any difference in pharmacokinetics or biodistribution in patients aged 65 and over. Drug interactions. Systematic endocrine therapies that target estrogen receptors. Certain classes of systematic endocrine therapies, including ER modulators and ER downregulators, block ER, reduce the uptake of fluoroestradiol F18 and may reduce detection of ER-positive lesions after administration of Cerianna. Drugs from these classes, such as tamoxifen and fulvestrant, may block ER for up to 8 and 24 weeks, respectively. Do not delay indicated therapy in order to administer Cerianna. Administer Cerianna prior to starting systemic endocrine therapies that block ER. To report suspected adverse reactions, contact Xianexa US Corp., a GE healthcare company, at 1-844-946-6392 or FDA at 1-800-FDA-1088 or fda.gov/medwatch. For information related to Cerianna, please email your inquiries to medicalaffairs@xianexa.com. Thank you for your participation in this event and your interest in Cerianna.